This is WETA 26, Washington, D.C., broadcasting in stereo to your community in suburban Maryland, Virginia, and the District.
The human immunodeficiency virus is not, in the strictest sense, a form of life. Until it is inside a host's body, it is no more alive than a rock or a stone. It is a protein-coated mass of genetic instructions, 150 times smaller than the white blood cell it attacks. After penetrating, it multiplies until the cell bursts and dies. This continues for years. Cell by cell, the virus destroys its carrier's immune system. The person becomes ill from a series of infections that are progressively serious and rare, and finally fatal. This is AIDS. And this is the AIDS Quarterly with Peter Jennings.
Tonight on the AIDS Quarterly, intravenous drug users afraid of AIDS and desperate for help.
I'm breaking out shivers all over my body, open sores.
Is there any counselor at all that could take her out?
Just how much closer is science to finding a treatment? And what it means to be a doctor in the age of AIDS.
And I wonder sometimes, am I kidding myself? Will I be overwhelmed at some point?
Funding for the AIDS Quarterly is provided by a grant from the Robert Wood Johnson Foundation. Resources making a difference in the health care of Americans.
Good evening, I'm Peter Jennings, and this is the spring edition of the AIDS Quarterly. Another effort by us to shed some light on this painful problem which we all face. Just in case we didn't make the point forcefully enough on the first edition of this broadcast, this is everyone's problem. Since we were last here 2 months ago, 2,500 more Americans have died of AIDS, and nearly 4,000 others have been newly diagnosed as having the AIDS virus. Now, we're not going to take your time this evening to tell you that AIDS is coming to your town, because you will know as the burden on your public health service gets heavier. On this broadcast tonight, we will ask what we can expect in the way of new public money for AIDS. In many parts of the country, hospitals are in danger of going under because of the additional financial pressure which AIDS has created. No, tonight our focus is on people who work in those hospitals and the new group of AIDS patients they are having to care for. Remember at the beginning when everyone said it's only a gay disease? Then we woke up to the fact that it was increasing even more rapidly among those who take drugs intravenously. And now it is spreading to their partners and their children. That's why the war on AIDS is also the war on drugs. Our first report is from Jay Shadler.
Today, there are as many as 1.5 million intravenous drug users in America. A quarter of them may carry the AIDS virus. The connection between AIDS and drugs has become a fact of life.
Well, the wisdom on the street is that if you continue to use, you're going to die, and you're going to die soon. If you clean up, you have a chance of living.
In record numbers, addicts are pouring into treatment centers like the Haight-Ashbury Drug Clinic in San Francisco, looking for detoxification and counseling. But those clinics are already bursting at the seams.
I've been calling here every day for 2 weeks. Every day I haven't missed. And they tell me no, 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 no. And the day I said, fuck it. I'm just going to come.
Cindy is 40 years old. She's a heroin addict, and she's terrified of AIDS.
I got open sores all over my body, my back, my butt, my chest, my face.
Yeah. How big do you have it?
About $200
About $200 a day. What are you going to do if you can't get in?
Steal.
Steal. Yeah. Do you know your HIV status? You had the AIDS test?
I had it in jail. I just got out of jail in December. But I'm breaking out shivers all over my body. Open sores.
Is there any counselor at all that could take her? I'd be real interested in what she's got in the way of this infection.
Day after day, the staff is pushed to its limits.
All right.
Oh, wait outside.
Okay. Every time we take somebody in that we don't have room to take, it further stresses this place. Some days we put 120 people through this little building. We're sitting right in the middle of the AIDS epidemic. We're sitting right in the middle of the crack epidemic, and people are frantic to get in.
There's no beginning, there's no end. Where do you go when you have no home? After 18 years of having a home and they take it away from you because you have 2 strokes and your kid dies and you end up on the street, where do you go? Who helps you? Nobody. Nobody. The drug addicts help you. They get you loaded and then you become a drug. Oh, man.
When I send somebody away, I have this awful fear that that individual might go out and share needles that day, that that individual might go out and have unsafe sex, that that individual might infect another individual.
As Cindy waits outside with her boyfriend, a counselor searches for another slot.
Oh, fantastic.
Lucinda, I don't have room for your old man. I could admit you, but I don't have room for your old man. I don't know how soon I'll be able to get him in. Any idea? Maybe tomorrow. I don't know. You know we don't do admissions on Fridays. We do tomorrow, but I don't know.
We come tomorrow?
I'll try.
That's important. All right?
I said tomorrow, you come tomorrow.
Okay. Don't worry about it.
Cindy's story is not unique. Similar tales can be told at most of the nation's 5,000 drug treatment clinics. In fact, the flood of new AIDS cases among IV users has produced waiting lists in 3/4 of our cities.
The system is like exploding. We don't have enough jails, we don't have enough treatment programs, we don't have enough educators, we don't have enough counselors, and we don't have enough money. And so we do have plenty of AIDS, though.
Indeed, during much of the 1980s, as AIDS cases among IV drug users soared, federal money for addiction treatment fell. There was an infusion of money in 1987, but not nearly enough to meet the need. In some states, like New Jersey, waiting lists are now 8 months long.
And what do they do while they're waiting? 8 months for treatment here. Spread AIDS. So that's what we've decided to do here. Spread AIDS by not letting people into treatment.
How you doing, Al?
Traditionally, addicts in drug treatment receive doses of methadone. A synthetic narcotic taken orally, it blocks the craving for heroin.
Okay, you take it easy.
But methadone is itself addictive, and addicts frequently return to heroin after methadone, just as Jeffrey did.
I've tried outpatient methadone 3 times in this city, and it doesn't work. The reason is that when you start taking methadone, you're high. You feel high at the beginning of the program, and as they decrease the dosage, you start to feel sick. And if you don't have any kind of support system, you wind up using anyway.
Jeffrey led a dual life, a computer professional in a West Coast corporation and a heroin user.
You know, on the one hand, I would be working during the day and be involved in the corporate world. And then at lunch, I would have to run downtown and buy the drugs.
How you doing?
About the same as you.
Yeah. You see Philly then?
I've heard Buster's has the best stuff down here.
Yeah.
Going through the dope sickness every day, here's what it's like. I wake up extremely sick, like a flu like a terrible flu. Knowing that all it takes is one shot of dope to make me feel like a normal human being. Not to get me high, but just to feel normal.
What happened?
I got busted.
Yeah? You got busted? I gotta get some money together.
By the time I finally did all the things that it took to get the relief that the bag of dope gave, using clean needles was like low on the priority. It was like getting it into me, which was real important. And although I've been aware of AIDS for years, and my best friend died of AIDS in September, my best friend from high school, I still have very often done high-risk behavior.
With the infection spreading and treatment either unavailable or ineffective, the streets have begun to produce their own solutions and curious heroes.
Bleach, water, cotton, cooker, condom. The bleach, if you got to share, you clean the works twice the bleach, right? Just try to stay healthy, right? Don't share works, cookers. If you find an old cooker, put bleach and clean it out. I'm serious. The AIDS is just terrible. You could die from the AIDS.
34-year-old John Parker is an ex-addict who has decided to wage his own personal war against AIDS. And so he goes where society's professional healthcare workers rarely venture.
To be effective, you have to cross that barrier. There's two worlds. There's the addict world and the straight world. You have to go to the people.
With a small band of volunteers he calls the National AIDS Brigade, Parker takes to the streets every day, risking arrest by handing out clean syringes and packets of AIDS information to addicts who crowd him wherever he goes.
Thank you.
Brooklyn.
Here's the thing with bleach. If you're going to share, share with the bleach, right? You got your own water, your own cook, your own cotton. You can't share nothing, all right? You know that. You can't use no one else's water, nothing. You know what I mean?
Boston.
The kid's something that's going to kill you.
What they think is that we don't care. The drug addicts don't care. That they like sharing.
No. They care, you know. But I mean, people that have never been sick don't understand.
New Haven.
I got these in the car. Just dump them out right here.
At every stop, the addicts bring their dirty syringes, some no doubt carrying the AIDS virus. And they trade them for the clean ones Parker has brought.
We're not lax out here. We all talk to each other about what's going on and how to be safe with each other, and we're concerned about each other, regardless of whether anybody thinks so or not.
If you have to share, you clean it with some bleach.
This is one resource that we have. This every Friday night, where we come and get something clean. That's one day out of a week, out of 7 days. You understand me? These are throwaway syringes. You understand me? These things are supposed to be used once and thrown away. People are using these 600, 700 times. You understand me? And then you get to the point where you get exasperated and you say, hey, give me yours. Okay, it's no. You know? And that's the kind of thing we're trying to stop, but we can't stop it because we don't have access to new works, new syringes and stuff.
Yeah, I'm going to give you a set of works. Right? There's cops down there. I don't want to get busted by them cops.
Handing out needles like this is illegal here and in 11 other states. But for Parker, it's an extreme measure for extreme times.
Can I get a set here? Yeah, here you go. All right. We got a kid here, right? We're just trying to... We don't condone shooting drugs. We don't even condone giving clean needles. But we're just trying to keep addicts AIDS-free till they get in treatment. Just, you know, try hard to stay AIDS-free and just know there's some hope out there, you know? Thank you. You know, it helps out. Thanks a lot. Thanks, boss. Good luck, man. Try to stay AIDS-free, right? Right on. Thank you. Needle exchange work is really cost-effective. For $15, I can buy 100 needles. For that $15, we can keep 100 people AIDS-free for at least a week. Right, $15 wouldn't buy an AIDS patient 1 hour in the hospital.
So John Parker will return to the streets he knows so well.
This is St. James. This is Arlington and St. James, right across from the Greyhound station. There's a block of buildings here, and the cars go around and around like a parade of cars, mostly older white men looking for young kids. They call the youngest kids chickens. They looking for oral sex and anal sex, and the kids make $30, $40, and they go buy drugs with the money. And they can get the virus from having anal sex or oral sex, and they also get the virus from sharing needles when they buy the drugs and they use the drugs. There's a big need for AIDS education here. Do you turn tricks sometimes?
Yeah. Oh, yeah. There's so many of us, you know. There's so many of us that shoot drugs, you know.
It's too high risk. When you haven't...
Right.
When you're having gay sex, right, and then you shoot drugs, it's like it's double the risk, you know what I mean? It's more important.
Right.
Economics is connected with human lives, it's connected with morality down the line. The more money, the more the state has to spend on AIDS, for AIDS patients, and the more social programs are going to be cut, the more kids are going to be put out in the street, and it's like a vicious cycle. The more prostitution you're going to have, the more drug abuse you're going to have. I don't pretend to say I'm going to, make a big dent in the AIDS crisis, but isn't some handle better than no handle at all?
See that report once, see it many times. We know there are people who think of this as a problem so immense that even beginning to tackle it is intimidating. There is no question that we need leadership. And that's what we'd like to talk about next on the AIDS Quarterly. Joining us here this evening are John Parker, who you saw in that report and who, for the purposes of this discussion, John, we'll call a street expert. Dr. Burton Lee is a former member of the Presidential Commission on AIDS. We devoted a lot of time to that in the first AIDS Quarterly. Today he is the White House physician, which means he keeps his fingers on the president's pulse as well. And Dr. June Osborne, who is a leading member of the Congressional Commission on AIDS, which means that she and her colleagues are supposed to have a major influence on Congress. First, can I get some consensus from the two of you on this question of needle exchange? In only 12 states, I think, in the District of Columbia now, is it illegal to exchange needles. Are you in favor of it, Dr. Osborne?
Of
needles, yeah.
I think it's an absolutely imperative thing to do while we get treatment options available for poor people. People say that's no solution, and they get very angry at talking about needle exchange. But in the interim, as a stopgap measure to make needle access so difficult, so impossible that sharing is forced on an addicted person makes no sense at all.
Do you agree with this, Dr. Lee?
I do. I do.
The president does?
The classic discussion on this from the law enforcement people, and they're totally unified on this. The law enforcement people don't want people passing out needles because to them it condones the addiction behavioral pattern. On balance, it's something. It's something. I mean, he actually said it on film. He said, "I'm not trying to cure AIDS." He said, I know I'm not making the earth move or anything, but I'm doing something, and it is something. In studies, it doesn't, especially of the kind of populations that he's working with, it's very difficult to show that it works, but it is something.
And it has been looked at in the European populations and found that it does not intensify drug use. And the term condone sets my teeth on edge, because look what we condone if we don't do it. We condone young people who may have whatever percentage of hope. We condone their loss of hope. And that's a terrible thing to do.
One of the things you should be doing is you should be passing out condoms with
They do.
To the addicts,
because
they know it works.
Sexual partners that
we do. We
where you run into the
all the
difficulties.
education. Once you have the addict, then you have the chance to do the education. But when I was a drug addict, we should buy a cup of water in the morning. Everybody would use the same water. At the end of the day, that water would be bright red. 100 people use the same cup of water. So you just can't say, here's a clean needle. You have to give more education. And our group just doesn't give needles. We do education. Like, look for like high school students. A lot of young teenagers, especially the males, they think they're invincible. They can do anything once. They think they can shoot drugs once. Oh, I'm not going to get addicted. But you need an ex-addict to tell these people, tell the people that are going to reach them that no high school person, when the person shoots up for the first dozen times or more, someone has to do it for him. So that means any kid who says, I want to shoot drugs, he has to have an addict do it for him, because you have to cook the drugs up, tie yourself off, inject it. So no high school kid is ever going to use a clean needle. Because either the addict is going to deny that the needle is dirty, or he's not going to care. So you need to there's an urgency to get this out there. And that's why I kind of stressed about having these ex-addicts, because they know where the gaps are, okay? I mean, they should be people in schools telling these kids, hey, you're 14, 15, you're young, you feel great, don't think you can shoot drugs once. And it's like, really, it's like flipping the coin about getting AIDS.
Surely we also need to know that this is an era of political reality, and let me come back to you, Dr. Lee. What's President Bush going to do? How much of a priority is he going to make it? When's he going to stand up and make the speech, and when's he going to ask for the dollars?
I think the dollars aren't coming for a while. After watching the budget message on Friday, I don't see, all I see is cutbacks in Medicare, talking to Lou Sullivan, cutbacks in this and cutbacks in that. I don't see the dollars coming immediately for this problem. We asked for 3 or 4, even as many as $6 billion for the treatment of drug addicts with our interval report. Congress has not come close to being able to appropriate this kind of money. As a matter of fact, it was overwhelmingly the majority of the money that we asked for was for drug treatment programs for addicts. So I don't see the money coming. I do see a lot more public awareness speeches coming from the White House. Mrs. Bush is interested in this problem, and the president is as well.
And this, of course, is leadership, too, if the White House uses the bully pulpit. Dr. Osborne, you've been involved in public health. Is that the kind of leadership we need, and is that what you'll urge Congress to do?
Well, we certainly need that kind of leadership, and it will be very helpful. I think that the signals that have come from President and Mrs. Bush of their upcoming articulation of interest are very encouraging, and we've missed that sorely. So that's good news. But so far as what we need to encourage Congress to do and other people who hold the purse strings, I think we have to look at what we spend now as opposed to what we're going to spend later. It's not really an option that we're going to have several 100,000 sick people, sick young adults in an age group that's normally not sick at all, within the next few years.
So the system really is exploding, as the doctor from New Jersey said.
Certainly. But you can already see the seams stretching and sometimes bursting in parts of the system because it is sewed together so loosely. And we've got enormous amount of anticipatory work to do before that happens in many cities in the United States.
Do you mind playing a hypothetical with me?
All right.
I'm a congressman. I come from the Midwest. I've got 10 minutes to see you. Actually, I have 5. I have some questions for you. How big a problem is AIDS compared to all the other medical problems I have to vote on?
It is a prototypic problem which will help in a lot of other instances. The kind of health care thing that I'm describing is in fact generic. AIDS is putting the pressure on to show us where those loose seams are and how they can burst.
If I don't give money for AIDS to the degree that you want me to, what happens to the hospitals in my community?
They will face the kinds of problems that some of the New York hospitals are now, where they have to make decisions in the pharmacy budget about whether to buy this kind of drug for this kind of patient or that kind of drug for that kind of patient. A kind of an inhumane and unthinkable problem in a society as rich as ours.
But I had somebody in the other day asking for money on toxic waste, and I just don't know where to put my emphasis.
Well, I think that one's easy. This problem is absolutely here and with us and likely to overwhelm the system for existing diseases and not hypothetical ones. Not that we must not pay attention to toxic wastes, but that we must know that we are not talking a hypothetical. We are talking about a real American epidemic of such magnitude that we could toxify the whole environment and not reduplicate it.
Thank you all for joining us on the AIDS Quarterly. We'll be back in just a moment.
By special arrangement with the AIDS Quarterly, operators at the National AIDS Hotline are standing by to answer questions, to refer you to resources in your area, or to provide additional information. Call toll-free 1-800-342-AIDS.
At the very beginning of the program, we showed you how the AIDS virus attacks a white blood cell, and how once inside the cell, it multiplies and then destroys the cell, and then slowly cripples the body's whole immune system. It is that process which scientists study in order to come up with ways of stopping the virus. And they're concentrating on 3 main areas: blocking the virus from attaching to the white blood cell. Secondly, if it does get inside, stopping it from multiplying. And thirdly, dealing with the infections that come with a weakened immune system. Remember, it isn't the AIDS virus that kills, it is the infections that follow. In order to see it and understand it, look into the microscope. This is a healthy white blood cell. It is the foot soldier in the body's battle against disease. The first way to protect this cell from the AIDS virus is to stop the virus from attaching to the proteins on the cell surface.
CD4 is a protein which sits normally on the surface of cells. And the AIDS virus utilizes the CD4 protein on the cell surface as a portal of entry, as a doorway with which to enter and infect cells.
The strategy used by Dr. Groopman and his colleagues is to get this virus before it reaches the cell.
What's been done is to genetically engineer the CD4 protein in a decoy form, whereby this genetically engineered or free or soluble CD4 is capable in the test tube of binding to the virus and blocking it from interacting with the normal CD4 on the cell surface. That is, it basically prevents it from getting in the door.
What's been tried in the test tube is now being tried on people with AIDS. CD4 is in its first stage of clinical trials. Another new drug is also in the early stages of human trials.
It's a measured dose.
Last month, it was demonstrated at a news conference in Boston. Peptide T was developed by a team led by Dr. Candace Pert.
We've known for some time that the virus attaches itself to the so-called CD4 receptor in order to gain entry into a cell.
Dr. Pert's strategy is to block the virus's entry into the cell. Here's a better view of the same virus. Peptide T blocks the virus by binding to the cell surface.
Peptide T binds to the CD4 receptor and blocks the ability of the virus to attach and hence enter the cell, just like a dummy key can stick in a lock and block the access of a key that would turn the lock.
But both of these strategies for stopping the virus are still very experimental. A major body of research is concentrating on what happens to the virus once it penetrates the white blood cell. Once inside, it begins to multiply. AZT, the only approved treatment against AIDS, tries to stop this.
To me, an exceedingly important category represents those drugs that are antiviral, those drugs that directly inhibit the ability of the AIDS virus to replicate inside of cells and to destroy cells.
Dr. Samuel Broder found that a drug developed in cancer research, AZT, and a class of similar drugs, stopped the virus from replicating like this. Without AZT, this is what happens to an infected cell. The virus multiplies, then breaks through the cell wall, forcing its way out. Each new virus then becomes free to attack another white blood cell and start the process all over again. So the body's weakened immune system is left open to what are called opportunistic infections.
We had to discover the drugs for the treatment of opportunistic infections. In several cases, it so happened that we had the necessary drugs. We had only to learn how to use them properly. This has happened over the last 8 years. And now treatment of opportunistic infections is improving considerably. Some of them that used to be deadly, such as pneumonia, pneumocystis carinii pneumonia, are not deadly anymore. Most patients survive several bouts of this special pneumonia because it can be treated effectively and since very recently also prevented very effectively. So life is extended in people with AIDS just through the better treatment and prevention of opportunistic infections, and progress will continue.
And it's that progress, driven by the urgent demands of AIDS research, that holds hope for the future.
I think in the very long run, such as 10 years and beyond, we're going to have a vaccine, we're going to have effective treatments. Once in a while, somebody will be found to be infected. Such a person, I believe, will need to be treated probably continuously throughout his or her lifetime, but then will not have to live in any worse condition than somebody who has chronic diabetes or who has a heart condition that requires continuous treatment.
So for a change, at least all the news about AIDS is not bad, in part because we have the financial resources in America and also because there's been enormous pressure to mobilize those resources. But what about the rest of the world? Joining us now is Dr. Jonathan Mann, Director of the Global Program on AIDS at the World Health Organization, who's come to join us from Geneva. Dr. Mann, thank you very much for coming.
Thank you.
How are things out there in the rest of the world? We don't pay as much attention as perhaps we should.
Well, actually, things are not very good. It's a worldwide epidemic. There are now 148 countries that report cases of AIDS. There are problems virtually all over the world, and the same kinds of deep problems that the United States is facing is being faced by countries who don't have the resources sometimes that the United States
Where's
has.
it the worst?
There's really no one worst place. I think the biggest gap between the seriousness of the problem and the resources to take care of it is in Africa. But it's also serious in the Caribbean, in Latin America, and even now in parts of Asia, a real epidemic is occurring.
I was not long ago in Cuba, where they have gone to quarantine. If you have the AIDS virus, you are put into quarantine conceivably for the rest of your life. What does the World Health Organization think of that?
Well, we don't think well of it. In fact, the World Health Organization has very strong policies, including a resolution passed by the latest World Health Assembly that specifically states that discrimination against people who are infected should not be allowed.
Do you sense that there are other countries in the world, perhaps not as democratic as we are, that might want to go that direction?
Yes, and in fact, we often say that AIDS unveils hidden prejudices that exist already in a society, but AIDS brings them out. I think it's true politically as well. It brings out attitudes towards people, towards the relationship between government and individuals, and so it's no surprise that in certain parts of the world, the desire to use laws to constrain human behavior comes out again, and people lose confidence in the ability to educate and would rather have confidence in laws or in jails.
We heard in this last report Matilda Krim say that if you look 10 years or 10-plus years down the road in terms of drug treatment, it's going to get better, that people with AIDS will have their lives extended at least. In terms of AIDS as an international crisis, when does it begin to look better, or does it?
Well, I guess I'm optimistic as well. Perhaps not quite as optimistic in the way that she is, because I'm quite concerned about whether those advances in drugs, those advances in caring for people who are infected, will be available in the developing world. You know, there's a very long history of development of drugs and vaccines in the industrialized world, but their failure to reach the developing countries. And we have to do better than we've ever done before. It's a matter of simple equity, of justice, that something that comes from international science would be made available to everyone who needs it. And that's going to be a major challenge. I am not optimistic I'm not optimistic in the short run that we'll be able to do that, but I'm optimistic that we will be able to change the way the relationship between investigators and drug companies and governments and people, to change that relationship.
Let me give you a good live example. There's already a crisis here, or a minor crisis, about the cost of AZT to people in America. Are you saying that a government like that of the U.S. should make it its moral, legal responsibility to see that something like AZT is available to the developing world?
I think we should look at the way drugs are developed and the way they're tested and evaluated and who makes them and who supports them, and then at the social responsibility of those who produce drugs commercially. I think we have to look for a different equation, but after all, would it be conceivable in this world that an AIDS vaccine could be developed in, say, the United States, tested, say, in Africa, found to be effective, and then not available to people in Africa or Latin America? I think that's inconceivable, and I think that's one of the pieces of the picture of global solidarity that means so much to us. Because one of the things that this worldwide threat has done is, just like for the concern about the environment or for concern about nuclear war, it's a global issue, and it reminds us that it's one planet, and we must do something for each other, even if that means changing some of the rules.
Dr. Mann, thanks very much.
Thank you.
We'll be back in just a moment.
By special arrangement with the AIDS Quarterly, operators at the National AIDS Hotline are standing by to answer questions, to refer you to resources in your area, or to provide additional information. Call toll-free 1-800-342-AIDS.
Talking to Dr. Mann reminds us of the kind of burden which AIDS has put on so many people around the world. First and always, the patients. Secondly, the rest of us. Whether it's Africa or Arkansas, AIDS has put an enormous burden on the general health care system. And what about doctors? AIDS is different than anything they've ever treated before. We're used to doctors making all the decisions, having all the answers. But because AIDS is so different, they've had to practice a new art of medicine. Beth Israel Hospital in Boston is one of the country's great teaching hospitals. It has an innovative outpatient department where people come for their primary health care. They come here with all the usual illnesses and questions. In recent years, the practice has had to respond to a growing number of patients with special needs. Half the patients Dr. Harvey Macadon will see this morning will have AIDS or be infected with the AIDS virus.
Okay.
about 100 and then down to
Others have not been diagnosed.
Okay, let me just come. I'll just go talk to him for a minute. Hi.
But when something goes wrong with their health, they're worried.
I don't know what to think. You know, the first thing you said last time was don't jump to rash conclusions.
But you've jumped to lots of them?
Of course. You know, I'm making lists of things I'm never going to do in my life. But, well, I guess the questions I have are, is this an indicator that I may be HIV positive, that there are worse things down the line? I don't know. I mean, I just don't know what it means. And I guess that's what I need to discuss with you.
Right.
And also, should I get the test? I don't know. And would that make I guess the big question is, would that make a difference in how we approach things if we knew I was HIV positive or negative?
Yeah.
Jay has applied to graduate school, but over the winter he's had a series of infections.
Well, I think they may be...
Because the AIDS virus attacks the immune system, he's worried.
When did those come out?
Yesterday.
Yesterday. Do you think there have been any new ones today?
Now he has an outbreak of what is commonly called shingles.
So gross.
Huh. You know, herpes zoster is a very common problem. People have had it, you know, before, you know, HIV infection was even known. Healthy, non-HIV infected people get it all the time, and it's kind of hard to know what to make of it. I think which is not...
Dr. McAdon believes the decision to take the test is up to the patient.
And I think the issue about whether to be tested or not is, you know, is still complicated. To some extent, it depends on, I think, on how much you're going to think about it. You know, we could talk some, and, you know, we could talk more about it next week, and we can decide.
Harvey McAdon did not train to be an AIDS doctor. He's an internist. But he has learned about the disease because so many of his patients have tested positive and become ill.
You know, this is not few grand.
We don't have the old film.
No, radiologist calling it up.
Yeah, it certainly looks like.
Every doctor in the practice is now seeing at least some people with AIDS. Specialists from the hospital are brought in to give advice as the disease takes its toll.
So fatigued you can't make it couch to kitchen.
The young doctors in this hospital are among the first generation to go through medical school knowing AIDS is in their future.
As I understand it, in the history of medicine, there have always been plagues, and there have always been doctors who ran during the plagues, and there have always been doctors who stayed to fight. There were doctors who went into medicine because it was a nice career, and then there were those who went into medicine because that's where the need is.
What happened? There. When did you find out? Oh. How are you doing?
Another of his regular patients has tested positive.
Yeah.
Another person to help through the months and years ahead.
Right.
Another person scared of an early death.
Right, now I remember we talked about that when you were here last. Did you just find out today?
Doctors think death is the enemy. That's what we're sort of about. And so faced with a near fatal epidemic, it's hard not to feel helpless in the face of that at times. I would say that the optimistic part or the encouraging part is to see some people live lives in the face of a near fatal disease that they know they're either going to get or they have.
Dr. McAdon has seen Jeff before. Jeff has been hospitalized 7 times. He has AIDS.
The popular view is that when someone develops AIDS, their life totally falls apart. And yet a lot of people live with AIDS, go to work, and in fact redefine their lives in ways that in some cases they are described as more satisfying.
Jeff quit his job as an investment banker to become a full-time AIDS activist. He is living with AIDS.
I don't want to avoid talking to people about dying. I think it's important.
Take a deep breath.
And I hope I don't avoid it.
Yeah.
But I'd like to think that we can do that at the same time that we're also talking about what makes sense for today and tomorrow.
Where are you going to be in early May?
I'm going to go spend a couple weeks with my family.
It's important to have hope. Clearly people are doing better. There are treatments now which help people. And yet it's important to be realistic. And I see my role as being there to help do both. And sometimes I think, am I being too positive, too chipper, too hopeful? But I guess I've learned to take some of the cues from whoever I'm with, whatever patient I'm with.
I mean, the notion of being tested and being tested positive is like earth-shattering. I can't think of anything worse happening to me other than leaving here and crossing the street and being hit by a truck and being quadriplegic for the rest of my life. I mean, just If I feel healthy and I'm not suffering from any symptoms, I just would prefer assuming. I mean, I'd like to know for sure that I'm negative, but
well, I feel.
I'm going to be suicidal.
I mean, I feel quite comfortable with what you're doing, and I think I just didn't want to kind of go on without kind of letting us have a chance to talk about it some more.
I don't think I can be convinced to get over that fear.
One fear about the test is the threat of discrimination. In Dale's case, he has been turned down for life insurance because he will not take the test. He doesn't want to be tested, even though he has no symptoms of illness.
Blood pressure's good.
He feels he has reason to worry.
You know, the other thing about the test...
What?
Is that before David, I was so promiscuous. It still bothers me.
Yeah.
It still makes me nervous.
I'm not saying you should get tested. I just don't want you to think of it as a kind of bottomless pit.
I mean, you don't encounter this with other people? I mean, do I have an extraordinary level of fear about this?
No, not at all. I think a lot of people say what you're saying and feel what you're feeling. And I guess I've seen a lot of people who have felt that way who nevertheless do deal with it. And my only reason for bringing it up is that people do deal with it, and a lot of us are here to help you deal with it if you should want to be tested and you should find out you're positive. You won't be alone. I mean, people always talk about, you have to learn the art of medicine, and it seems somehow like a nice thing, but you don't really get the hang of what they're talking about. And I think caring for AIDS patients, I think I'm beginning to learn about what people are talking about when they say that. Because it is a situation where there's a lot of uncertainty, there's a lot of ambiguity, there's a lot of anxiety, not just on the patient's part, but also on the provider's part. It's hard for physicians, for nurses, for any kind of professional sometimes to work in a situation where they don't necessarily know what to do with all the data. They don't even know what data they should gather. And then also in a situation where how frequently patients know as much about the data as they do.
I'm doing like 2 to 4 acyclovirs a day. And I'm doing 4 to 6 AZTs a day.
4 to 6 a day?
Yeah, it depends on how I remember things.
Well, that's lower than half strength.
I know, but only by 1.
What? I mean, I would recommend taking at least 5. No, I think you should at least take...
But I'm not going to wake up in the middle of the night.
No, you don't have to wake up in the middle of the night, but I think what we could do is increase your dose.
I don't want to increase my dose.
You don't want to? How come?
Because I'm feeling fine. I've been feeling fine ever since I went off the goddamn stuff.
So all I was suggesting now is that we slowly increase the AZT dose. I don't think you need to go up to a full dose right away, but now you're taking sometimes less than half a dose.
Right.
So I think you should.
Fine.
I know you're feeling fine now, but the AZT doesn't necessarily work on a day-to-day basis, and it's to prevent something from happening 2 months from now or 3 months from now, as well as tomorrow.
Right.
I just got a combination of frustrated and really frightened.
While a routine appointment at the practice is 20 minutes, caring for AIDS patients can take much longer.
And the person who now has AIDS had been subsequently the weeks before in perfect health. You know,
I worry sometimes about what if I'm taking care of many people dying at the same time.
as subtly as it did.
Yeah. And I wonder sometimes, am I kidding myself? You know, am I really, will I be overwhelmed at some point? The fact that it sort of came on to him without any warning, what did that mean to you?
Because there's been things, I've been having a cough for a couple of weeks now.
It's uncertainty. It's a lot that isn't known.
Listening to him talk just...
It's the intensity.
It's like being slowly dipped in ice water.
It's people really kind of asking you things frequently that they really feel the need to know the answers to right away when there aren't really necessarily answers to tell. It's probably somewhat the fear of ultimately being overwhelmed by large numbers of people and feeling like I can't do what I would like to do for everybody.
Quickly it happened.
So, anything else here?
No, top of my head.
Do you want me to talk to your mother? Well, no, it's if you want. I mean, I don't...
Well, I mean, I don't think there's anything to...
I can just go out with you and tell her that everything's okay.
Healthcare is taking actually
The practice is struggling to deal with the increased number of patients.
120 of whom are ARC-AIDS, and roughly 80 are in the well category.
And to make sure none of its doctors is overloaded.
I keep asking Harvey to stop accepting his patients. And he doesn't want to.
Yeah.
But I think that's going to be a big problem real soon. It's going to be a real big problem real soon.
Yeah.
I mean, doing this by yourself or having an overwhelming number of patients that you have to take care of or see, I think just sort of, I mean, there's no question, it stresses you out. You feel bad. You go home, it's hard to talk, it's hard to communicate. And it makes it, you know, and you go to work the next day and you don't want to walk into patients' rooms. Because everything is going poorly or people are angry at you or whatever. And then you say, is this what I trained to do?
I would probably talk to them about HIV testing.
For doctors in training, it often means having to deal with someone their own age who has AIDS.
It just seems really unfair, is the only thing you think about is, it just really seems like some kind of evil force that there can be something around us that can take people's lives away and take them away in such an ugly fashion. I mean, it makes you angry in a way that that nothing else has affected me.
Doctors really are trained often not to use their emotions, to not attend to their emotions, either the emotions that patients bring up for them or the feelings that they have about their patients.
Joel Frost is a psychologist. The staff of the practice brought him in to help them deal with the emotional side of AIDS.
But understanding your own feelings in response to the patient, it's really both sides of it. And that physicians aren't generally trained to look at both sides of the experience. You can't just walk out of one patient's life and walk into the next and do that in a way that you're unscathed.
I want to ask you if you're afraid of death.
Huh?
I want to ask you personally.
I think so.
Yeah?
Yeah.
Well, maybe I'll help you with that.
Okay. I think most people are until they really sit down and try and figure it out. Or they have to go through it with someone. I've actually never had a close relative die. So that worries me.
Your parents are still around?
Yeah. Parents.
Me neither. I had grandparents who are 95. Man married 72 years or something.
Wow.
My family knows nothing about this.
They know nothing about
death.
Uh-oh.
What Harvey Macadon has learned from his patients with HIV disease, he has begun to share with other doctors.
Somebody with HIV, when I expected it.
He helped organize a course to bring together experienced practitioners and doctors from smaller cities who are just beginning to see people with AIDS.
Sadness, and it's hard to get it vented.
The idea of having a picture of this patient that you see that's healthy and 25 years old and HIV positive, and have a picture in your mind that that patient is going to go down that course. I believe as physicians, if you have that picture, that's exactly what's going to happen to those people. And to be in the profession with that as your philosophy or as your mental set is wrong.
I guess what worries me sometimes is that I worry that I can get very enthusiastic and very into helping people live, but I worry that I'm not allowing them to talk about their concerns about dying. And, it's like I find myself checking myself several times with people to wonder, is this the time we should begin to talk about some of that? Or are they going to feel like I'm denying the reality of the situation? But, with the exception of that, I actually find your view of not looking down the end of the film very helpful for me, because I worry sometimes about my not doing that. It's one of those things that's just context, I think, for the primary care.
Harvey Macadon believes that as the disease spreads across the country, its needs will have to be met not by AIDS specialists, but by general practitioners.
Not had any experience with AIDS, and I hope you can get something out of this that'll help.
Hi, Mrs. Tucker. I'm good. How are you? How you feeling?
Okay, I guess.
Good.
What AIDS is doing is it's sort of the point man, the vanguard of the wave, which I think in some ways is turning medicine back to the old family practice of getting away from specialization, which sort of dehumanizes patients in a way. And I think it's reminding all of us of the old images that we kind of carry around of the country doctor who came in and took care of the family from birth to death and took care of all the illnesses, not specific illnesses.
Here, let me get the phone number. It's funny, when I was a kid, my father just retired. He was a dentist, but he worked in his own little office and had just by himself and didn't even have a hygienist, kind of had a secretary assistant who helped him. And when I was growing up, I always thought, God, it would have been great if he had this big fancy office. And but in the last 5 or 6 years, I realized that in many ways he's become a real role model. He was always available, didn't really care if people didn't have, insurance, saw anybody who came to see him, and really his goal was to take good care of his patients. Well, have you thought more about the issue around being tested?
Yeah, as a matter of fact, I called today about the anonymous testing centers.
Mm-hmm.
And
a lot of what's happened to me over the past few years is learning what he probably could have taught me years ago if I was really willing to take it in.
if I'm negative, then the health problems are probably isolated, and I can sort of proceed.
Yeah. Can I take a look at that?
Sure.
Oh, actually, it's far better than last week. Dramatically improved. I guess I'd like to think that in 10 years I'll have You know, a lot of patients who I take care of who aren't sick anymore.
You're on your way to school? What's your class tonight?
Oh, I'm taking a Spanish course.
Oh.
I'd like to think that there will be a lot of people who I met at a time of a great crisis, and the crisis will be over. I've learned to like to be a doctor in the process here.
The new art of medicine. And that's where we end this second edition of the AIDS Quarterly. We will be back in the fall. I'm Peter Jennings. Good night.
Funding for the AIDS Quarterly is provided by a grant from the Robert Wood Johnson Foundation. Resources making a difference in the health care of Americans.
The AIDS story continues with A Death in the Family, coming up next at 10 p.m. Stay with us.
Special arrangement with the AIDS Quarterly, operators at the National AIDS Hotline are standing by to answer questions, to refer you to resources in your area, or to provide additional information. Call toll-free 1-800-342-AIDS.